It's another busy day here at the AC Congress in Amsterdam, I can tell you. Sorry for being a few minutes late to be with you. I just rushed out of the meeting of the Digital Health Committee to be with you and share with you 45 minutes in this interesting and important symposium on the interaction of atrial fibrillation and hypertension, and consider and think and talk about technologies that will enable us to diagnose both drivers of morbidity and mortality in the field of cardiovascular medicine. We have a great program. We have 3 presentations, and hopefully we will have at least a little bit of time at the end of the presentations to go into interaction with you and to discuss the important items that have been presented. Let me open my presentation as the opener for our symposium. I would like to share with you some thoughts about the early detection of atrial fibrillation and rhythm control for the prevention of strokes and the interaction to stroke. I have no conflicts of interest to disclose with you. Hypertension and atrial fibrillation are in a very difficult and dangerous relation, as they promote each other in the way of a classical vicious circle. Millions of citizens and patients have undetected arterial hypertension, atrial fibrillation, and a significant number has both. There are clinical trial data that I will share with you later on that more than 70% of the patients that are diagnosed with atrial fibrillation included in trials also have hypertension. The vast majority of patients and people affected by hypertension and atrial fibrillation do not know that they are carrying these specific risks for severe complication. The most severest complication obviously is stroke, and they stay less symptomatic, asymptomatic at preclinical stages for a long period of time. And in this period of time, the citizens and the patients are at specific risks for developing the complications related to AF and to hypertension. And it does not matter whether or not the state of disease is asymptomatic, the risks got along with that as in symptomatic patients. This is taken from a beautiful recent review article in 2022 from Dominic Linz and colleagues explaining and exploring the interaction between atrial fibrillation and hypertension. And as I said before, both drive each other in the classical form of a vicious circle. Why it is so important, I already mentioned that because of the AF-related and hypertension-related complications, stroke, left ventricular dysfunction, heart failure, but also, and that has been under-recognized for many, many years, the effects of atrial fibrillation on mental dysfunction, which are serious, leading to cognitive decline, substantial cognitive decline, leading to a higher incidence of Alzheimer's disease, leading to depression, to impaired quality of life, and, of course, to a substantial number of hospitalizations. And I will remind all of us that stroke is one of the most cost-intense medical states of disease for the societies, if you calculate the total costs related to that. Hypertension and the risk of stroke. There are very, very good data, and this has been taken from a recent publication in patients with hypertension and type 1 diabetes, that arterial hypertension is one of the key drivers for the risk of stroke. And there are more and more data showing that this is a nonlinear relation between the intensity of hypertension and the increased risk for stroke. So early detection of hypertension is really crucial. I will share with you a couple of ideas why this becomes even more evident looking to up-to-date clinical science and studies. Introduction of medical therapy for hypertension according to current guidelines is crucial, and we have strong recommendations for antihypertensive medications, for example, in the ESC guidelines. And appropriate therapy reduces the risk for cardiovascular complications and also of stroke if you can bring the patients on a medical basis into normotensive range. However, there's also evidence, and this further addresses the idea of early diagnostics of atrial fibrillation, that although you bring the patients on medications in normotensive range, their risk of stroke remains higher as compared to people that are normotensive and have the same profile. And this is important because it opens up the window for primordial and primary prevention of arterial hypertension. Once they have the hypertension, you need to diagnose it very, very early because there is evidence that with earlier introduction of treatment, the relation between remaining stroke risk and the occurrence of stroke when the patients are on medication may be beneficial for the patient. And we will see the same in the field of atrial fibrillation diagnostics. So this is my clear message to you for hypertension and for atrial fibrillation detection. Early detection makes sense. What are the data for early detection of atrial fibrillation with respect to outcome? They are also getting more and more stronger in the direction that rhythm-controlled therapy provides huge benefits for patients, not only on quality of life, but also for the reduction of atrial fibrillation-related complications. So we will look to the rationale. We will take a deep relook on the East AFNet 4 trial, which was one of the most important trials to open up the window for early treatment of atrial fibrillation. 88% of the patients included in East AFNet, 88%, almost 90% with an early diagnosis of atrial fibrillation had hypertension. That shows this clear linkage between these two states of disease. Early rhythm control strategy was one of the key parts of the East trial, and the introduction of therapy was just on average median 39 days following the first diagnosed atrial fibrillation. So early diagnosis and early treatment with rhythm control, and then strong state-of-the-art rhythm follow-up in these patients. What is the relation to the risk of stroke according to the East data? We will take a look to that in a minute from now, and then I would like to share with you real-world evidence data that go in the same direction, that early diagnostics and early treatment really make sense. Just a very brief reminder on the strategy of the East trial. It was a strategic trial, usual care, as compared to an early and comprehensive rhythm control strategy. It's important to note that most of the patients that were set on a rhythm control strategy were treated with antiarrhythmic drugs and not with catheter ablation. The electrophysiologists, they promote these data sometimes with a perspective that ablation may have the same benefits. It may be the case, but we need to show it. This was an antiarrhythmic drug trial where you see the usual antiarrhythmic drugs and the suspects. It's important to note that the patients that were randomized to the strategy of early rhythm control mainly stayed in that strategy, and the patients that were randomized to usual care, which was rate control in almost all patients, stayed on that therapy to more than 80% during the complete follow-up. The primary endpoint was a composite endpoint, including stroke, cardiovascular death, acute myocardial infarction, and worsening of heart failure hospitalization. This shows you on the left side the outcome of the primary endpoint, and the primary endpoint was significantly affected by the rhythm strategy, as it was significantly lower in the rhythm control arm. On the right side, you see the incidence of different endpoints in both groups. And there were significant differences in 2 out of the 4 endpoints if you take a look to them in a separate manner. There was a reduction in cardiovascular death by 0.3%, and there was a reduction in stroke by rhythm control strategy. That means rhythm control is effective and reduces the risk of stroke and the development of stroke. I would like to share with you now data from real-world data sets that Greg Lipp and colleagues have put together that in essence call out the same message. The key question of this analysis was, if we map the East AFNet4 patient population on a huge real-world evidence patient cohort, will we see the same effects that have been described in East? Or will we see observations where the specific patient structure that you see in randomized controlled trials may have led to some of the observations made? So it's 5,300 patients in rhythm control and 17,000 patients in rate control, matched for the criteria for inclusion in the East trial. Here you see 2 of the main outcomes. Please focus on the left side. That's the endpoint of stroke. And you can see early diagnostics of atrial fibrillation, early treatment of atrial fibrillation reduces the incidence of stroke. This is an interesting analysis as it shows the time windows that we have years after diagnosis of atrial fibrillation and the effects that rhythm control has. And it's interesting to see that the effects of ischemic stroke may give us a wider window from the first diagnostics until the introduction of treatment as compared to the endpoint of hospitalization. This is my second last slide, and it again refers to the element of time interval between diagnosis of atrial fibrillation and introduction of rhythm control strategy. And as you can see, in all the analysis, the 6 months window and the 1 year window for stroke seems to provide substantial benefits as compared to later treatment. Actually, in 5 or more years of the diagnosis of atrial fibrillation, rhythm control may not have beneficial effects in these patients. I would like to summarize: early detection, documentation of atrial fibrillation is crucial. Early rhythm control results in a significant reduction of stroke and cardiovascular death. This has been shown by the EAST trial and confirmed by real-world evidence data. These effects may be synergistic to antihypertensive therapy as recommended in current guidelines. Systematic screening for AF should be done in selected individuals with risk factors for atrial fibrillation, such as hypertension. Thank you very much for your attention. So, I think we go to the next presentation, and it's my privilege to introduce Dr. Senoo from Japan. Thanks for coming over to Europe. It's a privilege to have you here. Detecting atrial fibrillation recurrence after atrial fibrillation at home. Your stage.
Thank you. Thank you for giving me to present my study today. So this is my disclosure. And first of all, so what is a complete? So I'm going to show you the video. So place the smartphone on the smartphone stand, and then press the start button. And then so place your thumbs on the top electrodes to record an EKG, and attach the side electrodes with your other fingers, and the EKG recording starts. Just like that. So remain still until recording the 30 seconds is completed. So that's it. So recording is completed. So you can see the Omron Connect and then so you can see the result of the EKG. So what is the AF detection accuracy? So the sensitivity is 96 to 98%, and the specificity is 86 to 96% respectively. It's very high sensitivity and specificity. So today I'm going to show you about our recent results of our study. So the ablation for atrial fibrillation is performed in many centers around the world. So we therefore investigated the usefulness of at-home EKG in the post-ablation management. So in this study, the persistent atrial fibrillation and the growing catheter ablation are enrolled for and followed up for 1 year after ablation. So the complete was not available commercially in Japan during the study, so physicians made all clinical decisions based on their usual practice. And the physicians and the patient were blinded to the complete results. So this is a study flow chart. Of the 128 atrial fibrillation patients enrolled, the 5 patients later withdrew their permission to the use of the data. So the final number of patients enrolled was 123, and 121 patients received atrial fibrillation ablation, and 94 patients were included in the final analysis set, excluding the patients for the reason presented in this slide. And the patient characteristic is here. The mean age was about 65 years old, and the 80% of the patient were female, and more than half of the patient had hypertension, and the mean CHADS-2 score was 1.1, and about 50% had long-term persistent atrial fibrillation, which means more than 1 year. So this is the Kaplan-Meier analysis of the time from ablation to first detection of recurrence AF. So during the follow-up period, patients were encouraged to take daily blood pressure and EKG measurements. At 12 months, 90% atrial fibrillation recurrence were detected in the usual care and 33% in the complete. And in the patient with recurrent atrial fibrillation found on both usual care and the complete, the time to first atrial fibrillation detection by the complete was about 40 days faster than the usual care. And in addition, we examined the additive effect of the complete on the detection rate of usual care on when used in the combination with the usual care. When the adherence to the complete measurement was divided by 80%, the effect of the complete on the detection of the recurrence atrial fibrillation in usual care was hazard ratio 1.71% for the low adherence group, but was significant for the high adherence group with hazard ratio 2.15. So that the significant adherence dependent difference of the complete was found in detecting atrial fibrillation recurrence. So this is a message from me that despite shorter measurement time, the complete detected recurrent atrial fibrillation more and faster than usual care by measuring them more frequently after atrial fibrillation ablation. This is because the recurrent patterns of atrial fibrillation detected by the complete include many short-lasting cases that would not be detected clinically. So finally, I'd like to introduce the ongoing study. So the 4,000 people aged more than 60 years old with hypertension and without a history of atrial fibrillation was recruited in the study. And then so after that, so EKG and blood pressure measurement at home in the morning and evening for 3 months. And after that, we will analyze the data and interpret the whether the possible atrial fibrillation is the true atrial fibrillation or not by our the physicians. So we have just finished the recruitment of those patients. So today I'm going to show you about the brief baseline data. The patient were registered nationwide in Japan over 1 year from April 2022 to 2023, just 2 months ago. And a total of 4,077 individuals were recruited from the northern area of Japan to the southern area of Japan. So this is the baseline characteristic of this study, and the mean age was 66 years old, and the BMI is about 25, and then complication is written by here, and the metabolic syndrome is about 1/3 of the study. So this is the last slide of my presentation. So the purpose of this study will be the 4. And one is we are going to detect the detection rate. We're going to investigate the detection rate of subclinical atrial fibrillation in hypertensive patients over a 3-month period. And number 2, we are going to investigate the relationship to their prognosis in real-world setting. And number 3, we are going to do the cost-effective analysis. And finally, we hope to do the identification of risk factor for atrial fibrillation incidence and the development of an AI model to prevent atrial fibrillation occurrence in hypertension patients. Thank you for your attention.
Thank you. Thank you, Dr. Senoo. Please join us here. And we have Faisal Osman with us from Coventry, UK, with the 3rd presentation, and he will share with us whether or not we can expect advantages in diagnosing atrial fibrillation in 30 seconds. Your stage, please.
Thank you very much indeed, Gerd. Good morning, ladies and gentlemen. It's a great pleasure to be here. This is my first face-to-face meeting here at ESC since COVID-19, and I have to say it's great to be back in person and great to see you all friends as well. So these are my disclosures. So we know that we have some very, very good guidelines on the management of atrial fibrillation. Our esteemed chairperson today was heavily involved in these guidelines that were last updated in 2020, and they provide a solid framework for which we use to guide management of our patients with atrial fibrillation. We know that the global prevalence, the incidence are rising, patients are getting older, AF is the commonest arrhythmia, and as the population ages, the risk factor burden increases. I'll touch a little bit on that. We're going to see more and more patients with AF, and something that was quite startling was that when you find out that if you're in a room with 3 people who are 50 or more, and I'm over 50, there is a 1 in 3 chance that one of those people will get AF in their lifetime, and that's quite significant when you think about it. Now, why is it important? You've heard from the speakers before, there are some very negative outcomes that are associated with atrial fibrillation, increased risk linked to death, increased risk of stroke, of course, that we're all aware about. The strokes are often denser, more severe, more life-changing, and more life-threatening. Links with LV systolic dysfunction and heart failure, recurrent hospitalizations, which then directly impact quality of life. Increasing recognition now, as you've also heard, with cognitive decline and dementia and, of course, depression. And people get symptoms, but there are a significant number of people who don't have symptoms. They're completely symptom-free. And actually, in that instance, somebody could be having atrial fibrillation, be at risk of all these negative effects, and not even realize that they are at risk. So how do we detect AF? And again, the guidelines are very comprehensive, and they tell us that we need a standard 12-lead ECG, or we have a single-channel tracing of 30 seconds or more that is diagnostic of atrial fibrillation. In people that are screen positive, where there is either an ECG, a 12-lead ECG, or a single-channel recording more than 30 seconds that is confirmed by a physician. So ECG really is the key to making the diagnosis. We know that there are different types of ECGs. Of course, the 12-lead ECG is the best, the ideal. Not everyone has access to that, and certainly not in a home situation. There are increasingly devices that are available that will give either a single channel and now also a 6-channel, which we'll briefly touch on. So there are a number of tools that can be used in screening of atrial fibrillation as well. Again, this is pulled straight from the guidance. Again, the guidelines give us an indication about opportunistic versus systematic screening. People over 65, advocation for performing opportunistic screening. But those who are over 75, where we know the risk is higher, having a more systematic approach to screening. And again, highlighting once again that to make a definitive diagnosis of AF in screen-positive cases, it's established after a physician reviews the single-channel ECG recording that shows AF for 30 seconds or more, or a 12-lead ECG that confirms the presence of atrial fibrillation. Now, risk factors, of course, are very, very important, and there are certain risk factors that we can't really do much about. Aging, we're all on that journey, we're all getting older. We can't do anything about that. Genetics, ethnicity, gender. However, there are a whole load of risk factors that we can do something about. And again, the guidelines are very clear in terms of identifying these and managing them. Hypertension, you've been hearing about, of course, very, very important. But there are others, diabetes, physical inactivity, obesity, which is a huge problem, certainly in the UK where I work. Sleep apnea, increasingly now being recognized as well. Smoking, excess alcohol intake, hyperlipidemia. So these are all factors that are very, very important. And this is also highlighted in the ESC guidelines. And also, interestingly, in the AHA guidelines. And in fact, lifestyle and risk factor modification is now a pillar in the latest AHA guidelines as well. Now, the European Heart Rhythm Association have produced some guidelines about digital devices and managing and detecting arrhythmias, a very comprehensive document. And again, highlighting there are different types of devices that are available to us now. You've heard about the Omron Complete, and I'll talk a little bit about that shortly as well. We have devices that are handheld or are wearable, devices that are looking only at the pulse, so plethysmography-based, or that actually look at the ECG. And of course, that's needed in order to diagnose atrial fibrillation. And we now have access to 1 lead, but also 6-lead devices, 6-limb leads that can be seen on handheld devices as well. So the guidelines highlight the importance of having ECG correlating with symptoms. For paroxysmal arrhythmias, these devices can be very, very useful and can be utilized in order to establish diagnosis. This is a flowchart, again, pulled straight from the guidelines about screening. Patients with prior stroke, again, we know that they are at higher risk and they should have more systematic screening. Those that haven't had a stroke, again, depending on their age, this flowchart nicely highlights the importance of comorbidities. Some of these, of course, we're all familiar with: hypertension, diabetes, obesity, but CKD, chronic kidney disease, COPD, increasingly recognized, and sleep apnea as well. And again, a nice sort of flowchart that helps us guide us in terms of using these wearable and handheld devices for detecting atrial fibrillation and the importance of it. We've been hearing about hypertension and atrial fibrillation and the combination. We know 1 billion people worldwide are affected by hypertension. We know that the combination of AF and hypertension is very dangerous. That combination almost doubles the risk of stroke. And stroke prevention, of course, is a top priority everywhere. As Professor Hindriks indicated, a stroke has huge financial implications for healthcare providers worldwide, not to mention the individual affected in terms of their day-to-day existence. So detecting these things is very, very important. The Omron Complete device that you've just heard about is a 2-in-1 blood pressure and single-channel ECG recording. It requires a smartphone and downloading of a Connect Omron app onto the smartphone and uses the AliveCore technology to record a single-channel ECG recording. And in Coventry, we wanted to do a little study just to have a look and see how patients and public volunteers would respond to this device. So we carried out this small study looking at patients who were attending an EP clinic, 15 patients. They were given the device, shown how to use it, given 2-week trial to go away, use the device. We also have a public volunteer group in the hospital. So these are members of the public who are interested in helping out with the research. And we had 11 public volunteers who were given sort of the device to look at in an interactive workshop and also a focus group. We collected data using questionnaires from them, and they all had semi-structured interviews by phone or in person. And we used thematic analysis to try and look at some qualitative data that was obtained. So some of the brief highlights of the study, the cohort was around about 60 years of age, both groups, quite a wide age range, so as young as 20, as old as 82, a fairly even split of males and females in both groups, and the overall themes that emerged from the thematic analysis was that the Omron device was very positively received by both groups. Both groups felt that it empowered patients, so patients were now given the responsibility of recording their blood pressure, which a lot of them were very used to, but actually also recording their rhythm. They felt that the basic level of technical skill was important, so these patients and public volunteers were shown how to use the device, and that was felt to be very important, that if that wasn't present, that actually that would be needed to help them. I quite like the little video that was shown by Professor Senoo showing the device, literally how it's used in 30 seconds. Users were very eager to learn about ECGs, and again, there was the feeling that actually if there were tracings, there needs to be support in place, because very often there is confusion about what the tracing might show, but that there was clear potential to integrate these sorts of technologies into clinical care. The two other points also that came up, interestingly, one patient, elderly patient, didn't have a smartphone, so couldn't use the device, and another patient had severe arthritis, so wasn't able to fully hold the device, given the size of the device. Now, electrophysiologists such as myself, we love doing AF ablation, but again, the important thing is detecting the AF early, intervening early, and actually that has been shown to make a difference in terms of outcome. And so it's not just about ablating, it's about getting in there early and making sure you detect AF early, no matter what technology that you're using. This is, again, another lovely slide from the SE guidelines talking about integrated management, being patient-centric, making sure we optimize stroke risk and symptom control, and then all of the other things beneath that, lifestyle modification, psychological support, patient education and support, and again, detecting AF and making sure that we give a good framework for patients and having a very MDT type approach. And this is my last slide. Again, having the patient right at the middle, a number of healthcare professionals that may be looking after the patient and advocating the CC to ABC approach. So confirm the AF, of course, which is very important, to characterize it, and then to use the ABC approach to avoid strokes and anticoagulation, better symptom control, and importantly, address risk factors and comorbidities. And I think I'll end there. Thank you very much indeed.
Thank you, Faisal. Great presentation. We have 10 minutes for discussion. Questions from the audience, from the floor. Yes, sir, please.
Hello, Piotr Kulakowski, Warsaw, Poland. I have a question to the study after ablation. Because we electrophysiologists pay attention to AF recurrences, we know about hypertension, but we don't have time usually to ask patients. So do you have the data on the values of blood pressure after ablation, and is this a correlation between blood pressure and recurrences?
Thank you for a great question. So, yeah, unfortunately, I haven't had that, but I'm still analyzing that data between the daily blood pressure data between and the atrial fibrillation recurrence. Thank you very much.
What was the acceptance of the the patients in the large cohort that you introduced to us, the 4,000 patients that you are currently analyzing, what is the compliance if you equip the patients with such technologies? Is it well accepted?
Yeah, it's also a good question. So all of the people are willing to do such a the super at-home EKG and the blood pressure, because in Japan there are lots of people having the blood pressure measurement in their home at home. So that's why they are very easy to get used to that. Yeah. So, but some of them, the look at the data. For example, some of them look at the data about the possible atrial fibrillation, but they don't do anything after looking at the possible atrial fibrillation. So I don't have a symptom. So why should I go to the clinic? So what should I do? So some kind of the situation had happened to our research. So that's a problem, I think. So we need to consider about those kind of the situation. So that new relationship between the physician and the patients.
Yeah. I personally believe that this area of hospital at home, healthcare taking at home, will become significant in the years to come, as it's a technology that will help us to cope with the increasing number of patients that that is impossible to be treated in the traditional healthcare system. The healthcare systems are overloaded, even in Central Europe and in Japan. And one of the quality improvers and by the same time bailouts is hospital at home applications, so home care. What is Dr. Osman, what is your perspective in UK? What are the main roadblocks for implementation? I mean, the technologies are there, the data are there. Why are we so reluctant to implement that on a large scale?
Thank you. Thank you. So it's a very good question. As with most things in life, money is important. These technologies, of course, aren't entirely cheap. But I think if you can show cost effectiveness, then they're important. The one thing we learned from our study was that patients given devices, you can't just give patients devices and leave them to it. You have to have some sort of solid framework of support. A number of our patient groups and those that were public volunteers, they took tracings, and several of them saw funny things because there was a lot of artifact, and then they panicked and worried. Luckily, they had research nurses they were able to call, who download and send the tracings. But if we're then expanding that onto a big mega stage, we need to make sure we have the support infrastructure in place so that patients can contact arrhythmia nurses or whoever it might be, their healthcare physicians or nurses, to then be able to perhaps interpret what is being seen. But you're right, the evidence is very strong, and I'm sure over the next 5-10 years these technologies will be taken. The one question I was just going to ask Professor Senoo, out of the 15 patients, 2 of our patients didn't return the complete device. Because obviously it's a big shining device, we weren't able to get the devices back off them. In your study, you had over a lot of patients. Did you lose any of these devices? Did you get them all back?
Is a ablation study or
either one?
Okay. Yeah, that's a good question. Only one patient couldn't get back that blood pressure for us.
See, that tells you about the population of Japan compared to Coventry, perhaps.
We are eager to chase all of them.
Yeah. We tried chasing hard as well.
Yeah.
But the patients weren't responding at all, not picking their phone up.
Yeah, I believe that it's also a huge educational task to open up the mindsets of citizens and patients to go into the direction of self-monitoring and self-diagnostics. It will be one of the key developments in the healthcare sector, particularly in cardiovascular, self-monitoring, self-diagnostics, and it will enable the patients also to to cover a different role in their own healthcare and healing processes. It needs to get along with educational programs, so it's kind of a part of a holistic strategy. At the end, it will deload the traditional healthcare system, it will improve the quality of care, it will reduce complications, and it will also reduce costs. If there are no further questions, we would like to thank Omron Health, the sponsor of the Satellite Symposium, for making all this possible. I thank our two presenters for superb presentations. I thank you. We thank all of you for your interest in the topics that we discussed over the last 45 minutes, and we wish all of you a further fruitful and enjoyable Congress here in the beautiful city of Amsterdam. Thank you. Take care.